All right, so let's talk about neurodegeneration. We could probably talk for a week on this topic and not cover everything. So there's a lot of different conditions that you have to know. We're going to stick today to the cortical dementias because those are the most commonly tested and the ones you'll see most often in clinic. A couple things have changed relatively recently. So whenever I was a medical student, it was DSM-4. DSM-4 defined these as dementing disorders or dementias. They've changed the term now. Now they would like for us to call them major neurocognitive disorder because the Latin derivation of dementia literally translates to insanity or insane. So it has negative connotations. Now, in clinic, do you think people are going to say Mr. Jones comes in who has a major neurocognitive disorder? No, they're going to say Mr. Jones is demented. So everyone just ignores the DSM-5, including me. Okay? It's defined as the progressive impairment of at least one or two of the following cognitive domains. So complex attention. The biggest one is executive function, so your ability to make decisions appropriately. Memory and learning is one of the defining features. Okay? You can also see language deficits, perceptual motor deficits, and social cognition. If you only have a deficit here, you're probably just a pathologist. Okay, and then by definition, the impairment has to be sufficient to impair with activities of daily living. So it can't just be a mild deficit, it needs to be severe. This is very common. It's not the leading cause of death. I think when this data was taken, I think this is 2013 data. It was the 5th leading cause of death. But what's interesting here is that most of the other causes of death are decreasing significantly or staying stable, whereas the rate of death for Alzheimer's disease is increasing dramatically. So it's going to, probably each time we run this data, it's going to get closer and closer to the top. In the US, about 85,000 deaths per year attributed to dementia. Most of these patients are older than 85 years old. Okay? The costs for dementia care are the highest of all chronic diseases, which is unfortunate because there's really nothing we can do about this. It's an untreatable condition. If you add up all the costs of dementia care, that's direct and indirect. That means people having to quit work to care for their demented family members. It's $600 billion spent in the US, and globally it's 1% of global GDP. Goes directly to treatment and care for dementia patients. And just tracking the data, it's increasing. Not exponentially, but significantly. And it's increasing more so in third world countries. So it used to be more of a first world country problem. But now that we're curing many diseases or mitigating many diseases that kill people as they're younger, people are living older, so we're getting lots and lots more demented people. Okay, so this is a diverse group of conditions, but they all share one common feature or several common features. Biggest one of these are all proteinopathies. So even though it may be different proteins that look differently biochemically and histologically, every single one of these conditions is characterized by the accumulation of one or more types of abnormal proteins. These proteins accumulate within the neurons in the brain, and they knock the neurons out, and that's where you get your symptomatology, is progressive loss of neurons. Okay, these diseases tend to be very predictable. So Alzheimer's spreads in the same fashion, regardless of how old you are. It always starts in certain brain nuclei, so nucleus basalis and the hippocampus, and then spreads to involve limbic structures, and then involves neocortex. Okay, Lewy body has the exact same march or progression, and it's consistent. Okay, historically, we only had a few diagnoses to choose from, mostly because we didn't really understand what was going on. So we had Alzheimer's disease, Lewy body disease, Pick's disease, and then non-Pick's frontotemporal lobar degeneration. And the thing that's shared amongst all of these is there's some sort of accumulation or body that's seen by H&E. So a pathologist 200 years ago would take a section of the brain, look at the section, and depending on what they saw by H&E, they would name the diagnosis. And essentially, if you had a demented patient that had no demonstrable inclusions or significant findings, then it went into this last disease process called non-Pick's frontotemporal lobar degeneration. So the patients would be severely affected clinically. The brains would be atrophic, but we would look at them by H&E and there'd be really nothing significant there. However, we are getting better at figuring out what's going on in these cases. So by molecular pathology, meaning that we look for specific mutations and specific protein accumulations, we're taking this non-PIX FTLD and basically teasing out the individual disease subgroups. So now we've got frontotemporal lobar dementia with abnormal tau accumulation due to tau gene mutations. We've got frontotemporal dementia with abnormal TDP accumulation. TDP is a heat shock protein that's expressed throughout the brain, and in some of these conditions, it's TDP that accumulates in the diseased neurons. In a similar subset of patients with motor neuron disease, if you don't find abnormal TDP, you'll find abnormal FUS. That's a gene that's actually seen in many cases of sarcoma. So it's called the fused in sarcoma protein. And then another group is FTLD with ubiquitinated inclusions that we find these CHIMP2B mutations. Now, I don't expect you guys to know any of these, right? I'm just putting them up there for your edification, that you can see that we're starting to tease out some of these individual diseases. When I ask you questions, it's going to be outside of the realm of this. It's going to be pretty much what was on the last slide. Okay, there's multiple ways to classify these neurodegenerative conditions. We used to do it based on what structure was affected. So we had the cortical, we had the basal ganglia, we had the thalamic. I prefer to do it based on which protein is accumulating. So we have tauopathies, which are characterized by abnormal tau accumulation. We've got alpha-synucleinopathies. Alpha-synuclein accumulates in Lewy body disease. That's the prototypical disorder. TDP-43 proteinopathies. And then polyglutamine disorders. And the most important polyglutamine disorder, the one you'll see most often if you see any of these, would be, you guys have any ideas? If anybody read the notes before the lecture? Yeah, Huntington's disease. That's the prototypical, but there's about probably 5 or 6 other ones in the brain. Okay, systems affected is the way we used to organize these. The reason why I show this is just because today we're going to talk primarily about cortical degenerations. Okay, here's probably the most irritating and frustrating slide of the entire lecture. Okay, there's so much money being spent on research into these conditions. There's labs all over the country that are working hard trying to figure out what causes these diseases. And we've made a lot of small discoveries, sort of insights into what the underlying disease mechanism is, but we still have no clue what the underlying cause is. So there's many, many different proposed explanations, and there's individual labs working on each one of these. So the thing that's shared, and the one thing that we know that's indisputable, is that these are associated with protein accumulation and neuronal degeneration, so impaired degradation of these abnormal proteins. People are focusing on oxidative stress. Excitotoxicity is a known factor that kills neurons. Obviously, cell death is in play. One of the big theories is neuroinflammation, so abnormal microglial activation in the brain. And then the two that are most important that we know based on epidemiologic studies is genetic factors and aging. Problem is, these are the most two important factors, and these are the two we can't control. One of the things they found out, actually one of the things I don't have up here is vascular pathology. So these patients have a lot of vascular disease in their brain, and of the things that you can control, the one thing is hypertension. So the biggest thing you can do for lifestyle modification to prevent you or your loved ones from getting Alzheimer's disease or other neurodegenerative conditions is controlling their blood pressure. My mom called me the other day and she said her blood pressure was like 200 and something over 120. She's on a lot of antihypertensive, and my sister's into this sort of natural healthcare thing, so she had her on an herb. And my mom thought because she was taking the herb, she didn't have to take her hypertensives anymore. I yelled at her for quite a time because exactly this, right? She was not happy with me. I was not happy with her. All right, but I told her, I was like, look, I've got kids. If you want to see them graduate high school, if you want to see them go to college, you want to see them get married, you got to take care of yourself. All right, let's talk about dementing disorders. Okay, first and foremost, the one that's most important, the one that you'll see most often is patients with Alzheimer's disease. So about 50 to 70% of clinical diagnoses of dementia fall under the rubric of Alzheimer's disease. A couple different types of disease defined by whether or not it's familial and depending on how early the disease onset is. So there's sporadic late onset, meaning there's no familial history and onset is after the age of 65. There's early onset if the disease starts prior to the age 65. There's familial late onset and familial early onset. Okay. Of these, there's a fairly strong genetic risk, particularly in the familial ones. These are usually attributable to a small subset of genes. I think we'll talk about those later. And then the one that's most interesting is Down syndrome associated. So patients with trisomy 21, invariably, if they live long enough, will get Alzheimer's disease. Why is that? They have 3 copies of chromosome 21. Okay, the APP gene is on chromosome 21, so it's a dosage effect. They have an extra dose of APP, which is one of the abnormal proteins that accumulates. Clinically, this is defined by memory problems early in the disease. In late stages, you start getting subcortical impairment. So that's when they start becoming mute. They get more emotional instability. Patients in end-stage disease are frail, immobile. But early on, it's just memory loss. Okay, Alzheimer's disease is not an inherently lethal disorder. Okay, it's not Alzheimer's disease that kills you, it's sepsis, it's pneumonia. Okay, but still the underlying cause, you have to ask yourself, okay, what's the proximate cause of death? So what's the thing that started these events into order? Alzheimer's disease is still the cause of death, but it's not the mechanism of death. So they wouldn't have had a decubitus ulcer and sepsis if they didn't have AD. Okay, so pathologically, what do we see in these conditions? Okay, first thing you see is brain atrophy. We define that mostly by just putting the brain on a scale and seeing what the brain weight is. Brain weight is tied to height, so the taller you are, the heavier your brain is. Right, that has nothing to do with the level of intelligence. So a heavy brain is not a smart brain. Einstein's brain is actually quite small. He wasn't a very tall dude. But Shaq's brain is probably the size of a watermelon, right? So I like when I'm down in the morgue and I'm holding a brain, like the number doesn't mean that much because I don't know how tall the patient was. So for me to judge a brain, is it too heavy, is it too small? I have to know how old the patient was and how tall they were. Okay, so after you look at brain weight, I generally say about 1,200 grams. So if it's significantly less than 1,200, then it's atrophic. If it's about 1,600, then it's too heavy. All right, so gyral atrophy. So on the left is a normal brain. So you'll see the gyri are nice and supple, right? They're almost touching each other, but they're not squeezing together. And there's minimal space in between the adjacent gyri, so there's no sulcal widening. Okay, compare this one on the right. Okay, the gyri are very atrophic, very narrow, and there's increased space in between, so there's gyral narrowing and sulcal widening. One of the best things you can look at is the Sylvian fissure, right? The gyri are surrounding the Sylvian fissure. Remember, this is called the operculum. It should be very full, and the Sylvian fissure should be closed. But once it starts to open up like this, it's called cupping of the temporal lobe, then that's one of the most sensitive findings for gyral edema, or gyral atrophy. Okay, other findings we see is hydrocephalus ex vacuo. Remember, as the brain shrinks down, the ventricles enlarge, just solely due to brain volume loss. And then we'll look down in the pons at the dorsal aspect, and we'll see the locus coeruleae are pale. Remember, locus coeruleus is Latin for blue dot, so if you can't find the blue dot, then that raises your suspicion for AD. Okay, here's a cross-section, coronal section of the brain. The lateral ventricles should come to a distinct point, so they should be angled up here, a nice little sharp point. When they're rounded like this, they're too big. The temporal horns of the lateral ventricle should not be near this large. And what happens here is your hippocampus, seen here with the little asterisk, is just too small. So as the hippocampus shrinks down, the temporal horn of the lateral ventricle increases. And you can see the Sylvian fissure, it's too much space here, this is too open. All right, take some brain sections, look at them under the microscope. This is what I'm looking for. There's two types of bodies that we see in the brain in AD. First one is neurofibrillary tangles. Second one is senile plaques. So neurofibrillary tangles, by electron microscopy, are defined by these paired helical filaments of abnormal tau. So tau is a microtubular associated protein that helps to support the axons in the cytoskeleton of the brain. And in AD, it becomes hyperphosphorylated and forms these long fibrils. And they tend to pair up together by EM. Okay, do you think I'd do EM on brain to make this diagnosis? Nah, this is solely for testing purposes. We have stains now that can show these things to us. So by H&E, this is what a tangle looks like. So here's a neuron, here's the nucleus of the neuron, and you get these sort of purplish, we call that amphiphilic linear structures that fill up the cytoplasm. So they're neuronal cytoplasmic inclusions made of abnormal hyperphosphorylated tau. There's many different stains we can do to pull them out, so they can be tough to see on H&E, so I can do special stains to find them. Probably the easiest one to do, and the one that we figured out how to do first, was silver staining. So this is a Bilchowski silver stain. And for you guys, the best way to recognize this is does it take the shape of a neuron, right? So you can see this pyramidal shape of the neuron, you can see the little processes sticking out that are full of tau. If you see an abnormal inclusion on silver stain that's shaped like a neuron, right, that is going to be a neurofibrillary tangle. That's it for this one. So the other type of body is a senile plaque. So remember, neurofibrillary tangles are comprised of abnormal tau seen in neurons. These are extracellular, so outside of neurons, aggregates of A beta protein. So A beta is abnormally cleaved amyloid precursor protein. When these guys are well developed, you'll see this central amyloid core. I always look at these as though it looks like someone accidentally put out a cigarette on the vinyl seat of an old 80s car. Right? I know you guys are way too young to know what that looks like, but my brother was a smoker when I was growing up, and if you looked at his car, there was all these little things where called it the cherry, the hot spot at the end of a cigarette would fall off, land on the seat, and it looks just like that. I actually didn't even come up with that. That's what my attending told me. Or my attending whenever I was a fellow, so clearly he smoked in his old vinyl car too. But yeah, it just looks like someone put out a cigarette on the vinyl seat. So it's just kind of disorganized. You got these abnormal neuritic processes. Sometimes you'll see microglia accumulating at the edge of these, and that's the amyloid core in the center. So there's a couple different stains we can do for this one. You can actually do an immunostain for amyloid precursor protein. These guys will be strong positive. They'll show up on that silver stain, the same one that highlights tangles. And this is a thioflavin S. So this is using UV light source on a microscope, and they just show up as these nice little green blobs. It doesn't really matter what stain I show you, right? I can show you silver stain, I can show you thioflavin. You can figure out which one it is based on the shape. So if it's shaped like a neuron, if it's sort of pyramidal in shape and has those processes sticking out, then it's a tangle. If it's shaped like these little fluff balls, then it's a senile plaque. That being said, in the lead up to the question, I'll give you an appropriate history, right? So you'll be able to tell from the history that I'm sort of leading you towards Alzheimer's disease. Then I would show you this and say, okay, what's the abnormal protein that's accumulating in there? So you have to sort of make two steps, right? Make the diagnosis, and then tell me something that you know about what's in here. A couple of things you see with Alzheimer's disease, so AD-associated pathology. One of the most common things is amyloid angiopathy. So that A beta protein that's also seen in what structure? Senile plaques can also aggregate around blood vessels. And it forms amyloid there, so you get this amyloid deposition, which gives you this double barrel appearance to the blood vessels. So here's the lumen with the red blood cells. Here's the endothelial layer, here's the pericytes, and then here's a layer of amyloid that's stuck at the edge. So here's one of the barrels, here's another barrel. What happens with these is these blood vessels can become very fragile with amyloid deposition and they can rupture. So one of the more dramatic causes of death in these patients is you have an older patient who's demented. One day they'll be fine, and the next day you'll find them dead in their room, and you look at the brain and it's just completely full of blood. It's because one of these guys ruptured. You can also find Hiranobodies, which are these eosinophilic inclusions in neurons of the hippocampus. What's interesting about these is that they seem to bridge from the cytoplasm to outside the cytoplasm. So they'll partly stick inside the neuron and partly protrude out. These aren't necessarily pathologic though, because you can see them in non-demented patients. Once we reach a certain age, about 50, 60 years old, I start picking up Hiranobodies. If I see a lot of Hiranobodies, I start considering, okay, could this be AD? And I look closer for other findings. This is entirely non-specific. They tend to go hand in hand with granulovascular degeneration. So I'll see GVD right next to Hiranobodies. GVD is the same thing. So in neurons of the hippocampus, instead of these eosinophilic accumulations or inclusions, you'll have these little vacuoles that have dark centers in them. Same thing, right? Seen in patients with AD, but also seen in normal elderly patients. So it's sort of a soft sign that makes me look closer, but I would never make the diagnosis based on these two. Okay, so I make the diagnosis of this disease not based on just finding plaques and tangles. I need to find a lot of plaques and tangles, and I need to find them throughout the brain. Because everybody, once they hit a certain age, starts accumulating plaques and tangles in the temporal lobe. So I can guarantee you if I look at the brain of someone who's 60, 65 years old, I'll find a few, but I need to find enough, right? I need to find them not just in the hippocampus, but I need to find them throughout the neocortex. If I just find them in the hippocampus, I'll just call it age-related changes and not call it AD. It used to be that you were required to have a diagnosis of dementia, but now they've removed that, so I can still make a pathologic diagnosis of AD, even if you don't give me a relevant history. Let's talk about the next type of diseases. The next one is FTLDs, or frontotemporal lobar degenerations. So one of the things I didn't mention when I was talking about Alzheimer's disease is that it tends to give you atrophy of the frontal lobes, the temporal lobes, and the parietal lobes, and it skips the occipital lobes. Where do we get dementia or atrophy in frontotemporal lobar dementia? Frontal temporal, right? So it tends to spare the parietal lobes. So selective frontal and temporal lobe atrophy, about 15 to 20% of cases of dementia end up falling under this diagnosis. There's three main subtypes defined by their clinical presentation. So there's behavioral variant. These manifest as more social inappropriate behavior. So these patients come in very dirty. They have poor hygiene. You get this thing called uncaring incontinence, where just no matter where they happen to be, if they feel like going, they'll go. So they'll be sitting in your office and they'll just pee on your floor. That would be an FTD patient or someone that's really weird. The other day yesterday I was coming back from Orange County. I'd cut brains in the morning there, and I was waiting at a stop sign, and there was, I don't know if any of you guys have been to Santa Ana. Ever since they cleared off the SART and kicked all the homeless people off the SART, they've all moved onto the sidewalks in Santa Ana. And while I was standing there, there was a guy picking up trash off the street. I kid you not, his pants were around his knees, and he was not wearing underpants. So I had to just force myself to look away. But he would fit into this, right? I just don't get it. I mean, it's got to be breezy at least. All right, the next one is semantic dementia, meaning there's not much in the way of memory loss, but you lose the meaning of your verbal and visual inputs. So you'll show the person a picture of a cat, and they'll say, I don't know what that is, right? And then progressive non-fluent aphasia is patients got good memory, they've got good comprehension, but they can't get the words out. So it's abnormal function in the perisylvian neocortex. That is what these brains look like. So look at the posterior side of the brain, or the posterior aspect of the brain. It's nice and supple. There's no gyral atrophy. There's no hydrocephalus posteriorly, but look at the anterior aspect. So the ventricles are huge, and there's severe frontal lobe atrophy. Look down here. Here's the temporal lobe. This part of the anterior part of the temporal lobe is atrophic. There's severe frontal lobe atrophy. And then starting about, here's the central sulcus right here. So there's no parietal lobe atrophy. Okay, I would never just show you this picture and ask you to make the diagnosis. I'd give you a leading history. Okay. We sort of already alluded to this. There's 5 main subtypes of FTLD. There's Pick's disease, which is probably about half of these diseases fall under Pick's. Then there's FTLD with abnormal TDP, FTD with abnormal FUS. Sometimes you'll get these cases, patients are severely demented, the brains are atrophic, but you see nothing abnormal. So there's no ubiquitinated inclusions, there's none of these other two. So this falls into an FTLD, no inclusions. What that means is that there's something going on there, we just haven't figured it out yet. So this used to be about 50% of cases, now it's down to less than 1%. Okay, we'll figure it out here pretty soon. I say we, I'm not doing any of this. I just work, but we as in people in neuroscience. All right, here's Pick's disease. It's now one of the least common tauopathies now that we've teased out the other disease processes. But I think it's one of the most interesting ones. So one of the things that's classic about Pick's disease, it's a frontotemporal lobar dementia, so it's mostly frontal, and then here's some severe temporal lobe atrophy, parietal lobe is spared. But look at the distinction between the degree of gyral atrophy. These guys are so atrophic that they start looking like the edge of a knife. So the classic term is knife-edge gyri. There's more sulcus than there is gyrus here. When you look at this tissue under the microscope, you see characteristic Pick bodies. So see this little round purplish inclusion in the cytoplasm of neurons? It's fairly well circumscribed. Those are Pick bodies, and you'll see them all throughout this atrophic cortex. This is down in the hippocampus, but anywhere you take a section, it's going to be chock full of Pick bodies. These are abnormal tau accumulations, but the interesting thing about these is that you can actually define the disease process by what type of tau is accumulating. So tau has two different subsets. They have different number of repeats of the microtubular binding domain. There's one that have 3 copies, that's 3R tau, and then there's 4 copies, which is 4R tau. Alzheimer's disease is both 3R and 4R. This is the only disease that's 3R only. Now we have no idea why it's a selective 3R. We haven't identified the underlying gene that's causing that. But it's just, we know biochemically what type of tau is accumulating. That being said, I don't need a 3R to make this diagnosis because this is the only disease you see Pick bodies in. The one case of Pick's that I saw in my fellowship, it was interesting when you took the brain out fresh. When you hold a brain fresh in your hand, it tends to be very floppy. Right? You try to touch it as little as possible until it's fixed. These are all fixed brains that we take a picture of. You can tell because they're standing up, they have some substance to them, but if you hold them fresh, it's like holding flan. Okay? Never look at flan the same now that I've said that. I've eaten it once since I sort of made that association. It really grossed me out. It tastes great, but it's just texture. When I took the brain out of this patient, the frontal lobes were like 2 floppy little appendages, and they were so floppy that they hung straight down. They were like this. They were pendulous frontal lobes. Then after you fix it, then it looked more like this, but it's very striking. That patient, what was interesting was she manifested as a hoarder. So she had been sort of off, even since she was in her 20s and 30s, very sort of schizotypal, very paranoid, had lost a lot of jobs, changed careers a lot. And by the time she died, her house was completely full of, what 2 things do people hoard most often? Newspapers? It's an animal? Cats, yeah. Her house is full of newspapers and cats, and she had spent $50,000 at the dollar store. I think that's 50,000 items, but I'm not positive. But yeah, it was interesting because they actually had pictures of her house in in her case folder that we were looking at conference. And it made me nervous just looking at it. But I'm kind of a clean freak. So. All right, here's the next diagnosis, or dementia syndrome. This is dementia with Lewy bodies. So now we're out of the tauopathies. So we're not talking about abnormal tau anymore. We're talking about alpha-synuclein. This disease has a lot of clinical overlap with Alzheimer's disease. And whenever I was a fellow, we had this conference where we would show each other, it was called an AD review conference. We had an ADC center, so all the patients would come in, they'd get extensive neuropsych testing, they'd get imaging, basically the most advanced dementia workups that exist at the time. And then when they died, we would examine the brain. And at the conference, the neuropsychiatrist would talk, the radiologist would talk, then the clinicians would talk, and they were forced to come up with a diagnosis, right? We think this patient has X, right? They had to commit for statistical purposes. And it was fun because us as pathologists, then we'd get to stand up and tell them the truth, right? What the patient actually had. It's about 50% accuracy. So even with the best of tools available, it's kind of a coin toss. So there was one day we had 4 patients we presented. 2 were thought to have Lewy body disease and 2 were thought to have dementia. It was exactly the opposite, or not dementia, Alzheimer's disease. So the 2 they thought were Lewy body turned out to be Alzheimer's. The 2 they thought were Alzheimer's turned out to be Lewy body. I'm not trying to discourage you, I'm just saying it's difficult to make an accurate clinical diagnosis here. So the things that you can look at to sort of push you towards the correct diagnosis is if you have Parkinsonism or Parkinsonian tremor, if you have visual hallucinations prior to the onset of memory loss, that pushes you towards Lewy body disease. If it's memory loss first, then these symptoms later, then it's more likely to be Alzheimer's disease. So try to tease out which one comes first. Because in severe Alzheimer's disease, you start getting tangles in the substantia nigra, you start losing nigral neurons due to tangles. So there's so much clinical overlap. You can also get tangles Lewy bodies in the olfactory bulbs. That's the very first place you find them. So theoretically, the very first clinical symptom for dementia with Lewy bodies is loss of sense of smell. That's why you should actually test your patient's sense of smell. It's not cranial nerves 2 through 12, it's 1 through 12. Just keep something stinky in your pocket and ask them if they can smell it. Another thing that's helpful is REM behavioral disorder. So if these patients act up at night while they're sleeping, so if they have new onset sleepwalking, aggressive behaviors at night, like acting out their dreams, that's one of the things that's more typical of Lewy body disease. Actually, my dad died of dementia. He died pretty young. I think he was 63, so early onset. And we always really wondered what he had because he was memory loss first, but towards the end he had severe REM behavioral disorder. So my mom was taking care of him. He'd wake up at night. He's like the most gentle guy you would ever know. And he'd wake up swinging, like acting out his dreams. One time he woke up and told my mom that she was a hussy and to get out of bed with him because he was a married man. My mom's like, yeah, I've been married to you for like 50 years. Well, not 50, but, a long time. I've always been curious what he had, but I didn't want to be that weird son that said, hey, let's look at dad's brain. So I just kept my mouth shut and just let it go. Okay, so dementia with Lewy bodies. This is basically neocortical involvement by Lewy body pathology, and we'll talk more about Lewy body pathology here in a second. So here's Lewy body dementia syndrome. There's such a thing as idiopathic brainstem predominant Lewy body disease, where the Lewy bodies are just in the brainstem. That's how the disease starts, and then later on the Lewy bodies spread up to the neocortex. That's why you get Parkinsonism first, and memory loss and dementia later, okay? So this is the most classic place you'll find Lewy bodies. This is in the substantia nigral neurons. Okay, Lewy body is an intracytoplasmic, purplish or amphiphilic inclusion that has a clear halo around it, right? So if I show you a picture of a pigmented neuron, right, this is the neuromelanin, that tells you this is a neuron in the substantia nigra that has a halo surrounding an inclusion in the substantia nigra. This is Lewy body disease, right, until proven otherwise. Okay, so this is a classic picture. You will see this picture again. You can do an immunostain to prove the diagnosis, though. If I don't trust my eyes on H&E, then I can do an alpha-synuclein stain, and it'll highlight these guys very nicely. But I don't need it, because I have eyeballs. I have an H&E, which costs $2.50, right? Alpha-synuclein costs like $300. I always tell the resident, because you get to this thing where you want to do expensive tests for everything because it's a cool thing to do, and you're curious, which is fine, but the single best study we have in pathology is the 200-year-old H&E stain. People forget that. All right, so Parkinsonism is a bradykinetic movement disorder resulting from loss of these pigmented neurons in the brainstem. Dementia is typically lacking early on in the disease, and some people never develop dementia, but those that do start in the brainstem and then spread superiorly. Pathologically, what we look for is pallor of the pigmented brainstem nuclei. That's the only gross finding that we can see. So there are 3 pigmented brainstem nuclei. First and foremost, starting from the top, working down, the substantia nigra is the easiest one to see. What level is the substantia nigra in? You got 3 levels of your brainstem: midbrain, pons, medulla. Midbrain, right? So midbrain's first. Okay, then moving down to the pons. That's where we find the locus coeruleus, the little blue dots on the posterior lateral side. The third pigmented brainstem nuclei is the medullary vagal nucleus. Right, so it's down in the medulla. It is so small you can't see it grossly. So you just have to find, it's usually a cluster of 5 or 6 pigmented neurons. This is the very first place that you pick up Lewy bodies. Actually, it's interesting. They think that Lewy body disease is attributable to abnormal gut flora or some sort of infection or process going on in the gut, because if you trace it down farther, the first place you can pick up Lewy bodies is actually in the spinal cord, and then they spread superiorly. So they start in the spinal cord, spread up to the medullary vagal nucleus, then to the locus coeruleus, then to the nigra, then up into the neocortex. So it raises the question of infection, right? What is going on in the gut that's causing this? So that's where this whole microbiome, bacterial processes in the gut is a pretty good theory for what's causing these diseases. Another thing that's interesting that was just published recently is you can take tissue from someone with Lewy body disease, in this case a rat, take that tissue and implant it in one area of the brain of another rat that's otherwise healthy, and that disease will spread and involve the entire brain. So something is going on that's mimicking an infectious process in these. So we're finding that Parkinson's disease is transmissible from organism to organism. Now, there's no evidence that happens in humans, and I hope it doesn't, because I've probably handled and grossed hundreds of brains that have Lewy body disease. Pretty sure that's how I'm going to die, is dementia, because I got a strong family history and I hold nothing but dementia brains all day. But we all have to die of something. All right, grossly, this is what we see. So we take a cross-section of the brainstem. On the left is normal, so here are the cerebral peduncles. This is the interpeduncular fossa, and then right between the cerebral peduncles, you'll see this dense band of pigment. Those are where your pigmented neurons lie. In abnormal disease states, look on the right here, the pigment doesn't just entirely disappear, but what happens is it sort of diffuses out into the adjacent parenchyma. So when these neurons die, the pigment doesn't just magically disappear. What happens is the cells die, the pigment disperses out, it gets eaten up by macrophages, and then the macrophages travel. So the pigment is more dispersed out into the adjacent. This is non-specific, though. You could also see this in severe Alzheimer's disease. So what I need to do is take a section, look at it under the microscope, and look for what? Lewy bodies, right? Alrighty. Okay, MSA. So MSA is another alpha-synucleinopathy. So remember, alpha-synuclein is the marker that we use for Lewy body disease. Alpha-synuclein also accumulates in MSA, but we don't have Lewy bodies. So it's more of a, you have to suspect it based on where you find the atrophy and do an alpha-synuclein stain, and then you find these small granular stains inside neurons and glia. So it's 3 separate clinical conditions with pathologic overlap. First one is called olivopontocerebellar atrophy. It's atrophy of the olive, pons, and cerebellum. These patients present with severe progressive cerebellar ataxia. They can also have a component of Parkinsonism, so it's atrophy of the substantia nigra and the putamen. And then some of these patients present with severe autonomic dysfunction, and that's involvement of the lateral columns of the spinal cord. So you'll see abnormal accumulations in the lateral columns of the spinal cord, which result in autonomic dysfunction. So how would that manifest clinically? What's the biggest thing? So patients stand up and they do what? Pass out, yeah. So postural hypotension. And then bladder incontinence. Each one of these, so you'll have a patient that has MSA that's predominantly this, but they'll have a little bit of both. So there's always some overlap between all three. These are defined by the presence of alpha-synuclein inclusions, but remember, they're not Lewy bodies. So you'll see glial inclusions, these little glial aggregates of alpha-synuclein. And then there's neuronal staining in the background. And then these abnormal neuropil threads, which are just neuronal processes that are full of alpha-synuclein. Now, you won't see this on H&E, so I would never show you an H&E and ask you to make this diagnosis. Okay, progressive supranuclear palsy. This is another tauopathy with a very unique clinical presentation. The reason why I put it here is because it can look just like Parkinson's disease because it has involvement of the substantia nigra. So clinically, it's more of a Parkinson syndrome. So patients present with Parkinsonian symptoms. They also have muscular rigidity. They have brainstem dysfunction, so difficulty swallowing, difficulty with conjugate gaze, supranuclear gaze palsy. And then cognitive dysfunction is very late in the disease process. Grossly, you see depigmentation of the substantia nigra. And then imaging, you can actually, there's some very characteristic imaging findings. This is the penguin or butterfly sign, or not butterfly, sorry. Hummingbird, yeah. Hummingbirds don't have big fat bellies, but it looks like the head of a hummingbird with its little beak. So that's due to atrophy of the posterior side of the brainstem. And then what sign is this? Yeah, Mickey Mouse sign. And it looks that way because you have atrophy of the posterior side. So Dr. Cole's already talked about PSP, correct? Okay, well, let me show you the pathology of it. Before, we didn't really talk about the shapes of tangles of plaques because the shape doesn't really matter, or the shapes of tangles. They tend to take the shape of the neuron that they exist in. So if it's a pyramidal neuron, they'll be pyramidal shaped. In PSP, though, you do tend to get this one relatively unique type of tangle. The tangles are very globose, so they're round and they look like a ball. Okay, so this is a silver stain showing you these ball-like tangles in neurons. And then the distribution is different. So they'll have some tangles in the cortex, some in the substantia nigra, which those overlap with AD. But then you also have severe involvement of the basis pontis, so the anterior part of the pons, down in the cerebellum, globus pallidus, and subthalamic nucleus. Now, all of these sites are paired in Alzheimer's disease. So just based on the distribution of these tangles, you can suggest the diagnosis. And also clinically, it should be a very different presentation. All right, there's other causes of Parkinsonism. So medication-induced injury to nigral neurons. Sort of go through this on your own if no one else has talked about it yet. All right, then vascular dementia. So sometimes dementia can result from strategically placed or significant numbers of infarcts. There's two main types. There's subcortical vascular dementia, which is just small vessel disease, which results in sort of a global white matter brain injury. And then there's large vessel disease, which gives you demonstrable localized infarcts. Both of them have the same clinical presentation. So it's dementia plus. It's going to be dementia plus signs of a stroke, so focal neurologic deficits. And this has probably already been covered, but clinically it's different because it's stepwise, right? So you'll get an infarct, you'll have clinical progression, then you'll be stable for a while, and then you'll get a second infarct. Your function drops quickly until you get your next infarct. So AD is relentlessly progressive, whereas vascular dementia is stepwise. Okay, grossly, basically we just look for infarcts, okay? So it's no different than what we'll cover in our vascular lecture. CJD is the type of infection that scares people most, right? Why are people scared of CJD? Yeah, it's transmissible, and we don't know how it's transmitted. Okay, so there's a lot of people that get CJD that we can't identify what the type or site of infection was. It may just have been like a de novo spontaneous misfolding, or they could have, eaten some deer with chronic wasting disease. They could have eaten beef in England. Like, there's a whole bunch of different risk factors, but most patients that I've seen have no demonstrable risk factors, so people are scared of the unknown. In pathology here, I have cut 2 CJD brains. One was clinically unsuspected, so basically I thought it was going to be an AD. It turned out to be CJD. And our lab manager, everyone's heads exploded, right? So they all thought they were going to die of CJD, and we had to disinfect all the machines. I had to go over and talk them down. Scientifically, the only way that we can prove that this is transmissible is by doing what to the tissue? Take a piece of infected person's brain, inject it into another organism, and then they'll get the disease, okay? So it's never been proven to be transmissible by just direct contact, right? So holding a brain with CJD. All neuropathologists have done this at one point or other, and I only know of one that's died of CJD, so the risk of infection is really, really low. So that's what I tell them. I was like, unless you took a piece of that brain and injected it directly into your brain, you're probably okay. I think that helps sometimes. Okay, so there's 2 main things that should raise your suspicion for CJD, or prion disorder. If the dementia is rapidly progressive, so if from the onset of disease to death is less than 2 years, all right, think CJD. Okay, Alzheimer's disease is usually 10, 20 years, same with the others. Not CJD though. And if you have a patient with seizures, myoclonus, prominent psychiatric symptoms, also think CJD. Pathologically, it's defined by the presence of spongiosis. So you get these clear vacuoles in the brain tissue and within the cytoplasm of neurons. You can confirm the diagnosis by doing a prion stain, and all this tissue will be dark brown. All right, Huntington disease. I think this is the last one we're talking about. So this is an autosomal dominant inherited disorder that's characterized by psychiatric symptoms and involuntary movement. So these patients have choreoathetosis, or dancing-like movements. They have cognitive decline. Early in the disease process, they tend to be very paranoid with delusions. The only Huntington's patient I've ever seen in real life was at the psych unit at the VA. And he was that, every psych unit has that one naked guy that won't keep his clothes on. This was our Huntington's patient. So every morning they'd find him in a different part of the unit, just standing around naked. He'd walk in people's rooms. It was actually kind of interesting. Remember this participation. So each generation, the disease is progressively earlier and earlier. Grossly, I suspect this disease when I see atrophy of the caudate nuclei. So here's normal for comparison. The ventricles have this nice sort of convex appearance. That convexity becomes a concavity. So the ventricles look big, and they look big because there's loss of the caudate. Okay, histologically, there's no inclusions that I can see here. So I don't see tangles, I don't see Lewy bodies, there's no PIC bodies. If I want to prove the diagnosis and I'm not sure, meaning the patient never had genetic testing, you can just do a polyglutamine stain. The reason why that works is because the trinucleotide that expands is CAG. CAG codes for glutamine, and these expanded glutamine tracks can be detected by an immunostain. So if I do a polyglutamine stain on a normal patient, this will be negative. On a Huntington's patient, it's positive. All right, that is it for this lecture. You guys have 2 minutes till the next one starts. Go play Frisbee.